Good morning, everybody, and a very warm welcome, and thank you for taking the time to attend the webinar today. I'm delighted to be with you to launch the People chapter of the Belfast City Profile. I'm Karen Casson, and I'm the Interim Chair of Belfast Healthy Cities and a member of the Profile Advisory Group. I spent a considerable part of my career working in public health and epidemiology. As this is a webinar, participants will remain muted with their cameras off, and we would encourage you to please put any questions in the Q&A box at the bottom of your screen. The presentation from the speakers will be recorded and will be uploaded to Belfast Healthy Cities website. If you're using Twitter, you may wish to include the hashtag #HealthyBelfast or include @Belfast in tweets displayed on the screen, and they're also in the chat box. So this webinar is the second in a series of webinars to launch the City Health Profile, and today we're going to be focusing on the launch of the People chapter. We will be joined by Dr. Ciara Fortune, the Regional Advisor for Healthy Cities in the World Health Organization, Erika Eisen, Expert Advisor to Healthy Cities, and Charlene Stoops, Director of Planning, Performance and Informatics from Belfast Health and Social Care Trust. The presenters will highlight key points of the data and opportunities to use it to inform work taking place to address health and well-being and to tackle inequalities in Belfast. And as you hear from each speaker, I would encourage you to consider how the information can be used within your own organisation and across partnerships. We would like to thank the wide range of partners who were involved in developing this piece of work for their time and their continued support. So our first speaker is Dr. Ciara Fortune, and we're delighted she can join us. And Ciara is going to speak on prevention and control of non-communicable diseases in the WHO European region. Ciara is responsible for Healthy Cities, health promotion and wellbeing in the regional WHO Office of Europe. Ciara has spent the last 25 years specialising in public health, equity, community engagement and the social determinants of health in various international organisations across the globe. Prior to taking up the position in Copenhagen, she managed the Social Determinants of Health and Violence and Injury Prevention Unit at the Regional WHO Office of the Western Pacific in Manila. So thank you, Dr. Fortune, for joining us today.
Thank you very much, Karen, for that very kind introduction, and good morning, colleagues. It's wonderful to see so many of you connected, and I'm of course very excited to be part of this very important and very timely session today. What I'm going to do over the next 10 minutes is that I'm going to be speaking to the work that we're doing here in the European region on tackling NCDs, and of course also linking that to the work that's happening within the Healthy Cities Network. So let me just see, my slide is not moving. Oh dear. Something is happening. There you go. Okay, so first let me take you back to 2015. So 2015 was of course a very historic year because that was the year when the Millennium Development Goals came to an end, and when the global community adopted the Sustainable Development Goals agenda. I think it's fair to say that there was much to celebrate. We saw a decrease in extreme poverty, an increase in life expectancy, and also a decrease in under 5 mortality. But at the same time, there was a recognition that not everyone had benefited equally from that progress. And in fact, inequity and poverty continue to be two of the greatest challenges of this century. And that, of course, is really important even when we think about addressing non-communicable diseases. We know that place matters, so where you're born matters, and we also know that inequalities do not just exist between countries, but also within countries. And that's why you've seen that I have put up a map here of the red line in the Washington, DC, where you will see that even within 17 metro stops, life expectancy differs significantly. And I say this because I believe that when we are addressing NCDs, we need to use that equity lens. And if we're zooming into the European region, you will of course see that this is a large, very diverse region. It consists of 53 countries. And as I said, it sort of spans, it's very diverse. So there is no size fits all, but we do see some common challenges, including that of urbanization. So we know that 2/3 of the region's populations live in urban environments. In high-income countries, we are seeing 1 child in 5 that still live in poverty, and a total of 1.4 million Europeans die prematurely each year due to polluted environments. Physical inactivity is responsible for more than 1 million deaths in the region every year. So these are some of the challenges that we are seeing here in the European region, and we know that these challenges can, of course, not be tackled by the health sector on its own. Rather, it requires a commitment working across sectors. Now, to contextualize this, I just want to sort of briefly speak to Jana's story. Jana is a young woman living in the east of the European region. And really what's characteristic of Jana's life is that throughout her very short life, she has been in touch with the health system on a number of occasions. But every time she has been sent back to the environment that made her sick in the first place. And of course, if we could change that story and ensure that Jana has access to a healthy diet, clean water, clean air, then her story would look very different. And this is, of course, what we are aiming to change. And this leads me to just highlight the general program of work, the WHO 5-year work plan that was implemented or adopted by member states 3 years ago. It sets some, our mission is to, 1, to promote health, 2, to keep the world safe, and 3, to protect the most vulnerable. And the way that we envisage doing that is that we've set ourselves some very sort of ambitious targets. So ensuring that by 2023, 1 billion more people will be benefiting from universal health coverage. 1 billion more people will be protected from health emergencies, and 1 billion more people will be enjoying better health and well-being. Now, that leads me to the European Programme of Work. This is our WHO regional programme of work here in the very region and has been adopted by our 53 member states. And we see that very much as the implementation plan of the GPW13. And central to this work plan is, of course, that of NCDs, recognizing that this is one of the biggest challenges that we have here in the region. And I should say that one thing is that it's a key priority to address NCDs, but we also have some flagship initiatives, including a flagship initiative that speaks to mental health, but also to that of behavioral and cultural insight. And these are, of course, all very much relevant to the work that we do on the NCDs. Now, to sort of implement that in more practical terms, we have an action plan, a 10-year action plan that was adopted in 2016, with really the vision to promote a Europe free of preventable non-communicable diseases, premature death, and avoid disability. This consists of 4 components, mainly namely that of health promotion, surveillance, sorry, that's my Danish accent, I can't really say that word, as well as health systems. And these are sort of the key factors that we speak to in implementing this plan. And I should say central to this plan is that of the best buys, because I think this is the one concrete way of really tackling NCDs that we can speak to. And what's quite unique about this is that it's really about tackling the major risk factors. At least 80% of all heart disease, stroke, and diabetes, and 40% of cancer could be prevented if these best buys were to be implemented. And this entails 88 interventions. You will find, if you take a look at it, that the best buys top 3 is that of reducing tobacco use, it's reducing the harmful use of alcohol, and it's reducing unhealthy diet. Now, we, of course, have a number of policies, as well as programs and tools and approaches that we use. And you will see that we have established a pan-European cancer movement, really working with a number of stakeholders to address cancer. Our regional director also established an advisory council on innovation to address NCDs, recognizing that this really requires looking outside of the box and really using that innovation lens, if you like, to ensure that we tackle this challenge. And we are also seeing in this region that we are using new approaches to, say, physical activity, including how we design cities, but also how we measure physical activity levels and estimate the socioeconomic cost of physical inactivity. So these are just a snapshot of some of the work that we're doing here in the region to address just that. Now, we do, of course, know that the Healthy Cities Network play an instrumental role in really addressing NCDs, but also really implementing the Sustainable Development Goals, which, of course, in turn also helps us to and supports the efforts to really implement both the GPW as well as that of the EPW. And what we are seeing, what's central to the implementation framework of phase 7 of Healthy Cities is the 6 Ps, as you know, and that is precisely looking at NCDs by supporting people living with NCDs, but also ensuring that local level health promotion and disease prevention is implemented accordingly. There's also a key focus on the built environment, so really looking at how we can design cities that allow us to and support us in being more healthy, and of course also ensuring that we have key coherence across different municipal policies, so ensuring that we really apply the health in all policies approach to ensure that we tackle the NCDs. Now, without going into details, I, of course, wanted to share with you that the Healthy Cities movement has been around for more than 3 decades. It's, as you know, a very historic movement. It has played a key central role in implementing the SDGs, but also ensuring that the NCDs are tackled in a comprehensive manner, and there is a lot that can be learned from the Healthy Cities movement. I think what's important as we think about where we are heading in the future is that together with our cities, we are really planning to implement the well-being charter that was adopted by countries during the last health promotion global conference. And the reason that I say that is that we know that there are so many lessons learned from the cities that are really tackling NCDs, again, using a health in all policies approach. We're also really looking in the future to really establish a narrative on health promotion, well-being, and local governance. And this, of course, is where the Healthy Cities Network will be absolutely instrumental, because again, we want to learn from the experiences such as Belfast. And I think today is a really good example of showcasing what is being done at the local level and thinking about how that can trickle up to the global level. So on that note, colleagues, this was just a very brief snapshot of what we are doing here in the region. And I, of course, look forward to hearing from other colleagues and learning from you today, and to further enrich this discussion. So I stop here. Thank you so much, colleagues.
Ciara, for that overview of the approach WH Europe are taking. And if you have any questions for Ciara as part of the Q&A session at the end of the webinar today, would you please submit them in the Q&A box. We are now delighted to welcome back, and we had Ciara the last one as well, Erica Eisen, Expert Advisor to Healthy Cities. And Erica is going to be speaking on the People chapter of the City Health Profile. Erica has worked in the health sector for the last 30 years, working across the spectrum from acute care to public health. She now specialises in public health, but looks at the public health aspect of healthcare, as well as the protection and promotion of health for communities and populations. Her particular specialties include health impact assessment, health and all policies, which we saw mentioned there by Ciara, and community consultation. Erica has been an expert advisor to various parts of the World Health Organization since 2003. So thank you very much, Erica.
Thank you for that introduction, Karen, and it's great to be back, as always, in Belfast to work with friends and colleagues. Okay, so as Karen mentioned, I'm going to take you through some of the data in the People chapter. I first wanted to start off looking at demography, just to give us an overview of that. Although the population is ageing in Belfast, it is not ageing to the same extent as the population in Northern Ireland, or indeed in other local government districts. Northern Ireland has the highest proportion of live births from Northern Ireland's total, but unfortunately fertility is low and decreasing. And the issue about this is that the fertility rate is lower or below the population replacement rate in the absence of migration to the city. So that's something that needs to be borne in mind when thinking about population and service planning. Belfast, however, does have an increasing share of Northern Ireland's international migrants, but it does have the largest percentage decrease in both internal and external migration flows of all the local government districts in Northern Ireland. Although the population is projected to increase by 2028, this will only be slight, and it's the second lowest percentage increase of all local government districts. However, Belfast has the highest level of ethnic diversity. It's higher than that in Northern Ireland, and the highest level of ethnic diversity among local government districts. So that's a quick run through of the demography in Belfast. And I just thought I'd give you a bit of a pen portrait of each of the 4 assembly areas in terms of demography. So Belfast East, it has a relatively small total population. The population there is relatively older, and it has the highest median age. If we look at Belfast South, however, that has the largest population and the highest percentage of people aged 16 to 39 years. So that's your younger working age population is highest in Belfast South. It also has the lowest median age and the highest level of ethnic diversity. If we move to Belfast North now, that does have a relatively large total population, but what's interesting about Belfast North is it has a higher percentage of people aged 0 to 15 years, so the youngest age group at one end of the spectrum, but then at the other end of the spectrum, it also has a higher percentage of people aged over 65 years. So that's quite interesting demographically in Belfast North, and that needs to be taken account of when service planning. Belfast West has the smallest population. Again, like Belfast North, it has a higher percentage of people aged 0 to 15 years. It has a lower median age, but even though it has a lower median age, the median age in Belfast West has increased. It's had the largest percentage increase between 2001 and 2020. And finally, Belfast West has the lowest level of ethnic diversity in the city. Looking at life expectancy in Belfast, this can be quite a complex picture when we get down to detail. But if we start off with life expectancy at birth on the left-hand side of this slide, we can see that Belfast has a lower life expectancy at birth for both men and women when compared with Northern Ireland, and it is also lowest among the LGDs for men and women. However, men do worse than women in terms of life expectancy at birth. If we start to look at the time trends, this is where it gets a bit more complex. So even though men have a lower life expectancy at birth than women, the time trend for men is increasing, so that's getting better, but it's decreasing for women, which is interesting. And the time trend at birth is also decreasing for both men and women in Belfast's most deprived areas. If we move on to life expectancy at 65 years, then again, it's lower compared with Northern Ireland for men and women. It's the lowest for men if we compare it with other local government districts, and it's the second lowest for women. Again, men do worse than women in terms of life expectancy at 65 years. But again, there's an interesting difference when we move down to look at the time trends. Life expectancy at 65 years is increasing for both men and women. But if we look at Belfast's most deprived areas, it's increasing for men, but decreasing for women. So even though men are doing worse than women, I think there's an interesting issue that needs to be looked at why now life expectancy is beginning to decrease for women, either in the deprived areas or just within Belfast as a whole. So if we look at this by assembly area, then Belfast South has the highest life expectancy for both men and women, whereas it is lower for men and women in Belfast North, and it is the lowest for men and women in Belfast West. If we move on to death rates now, which help us to understand the life expectancy figures, if we take three main indicators, so that's death rates for avoidable deaths, so that's deaths that could have been prevented, early deaths from circulatory disease and early deaths from cancer. And by early death, we mean a death that has occurred before the age of 75 years. Those are what we refer to as early deaths. If we look at these three indicators, then compared with Northern Ireland, again, Belfast has higher rates. Compared with other local government districts, again, Belfast is the highest. The good news is, though, is these time trends are decreasing for all of these indicators. So although the figures don't look great, some of the work that's going on in the city by the Trust and other organisations, both public sector and voluntary sector, the time trends show that the work that's going on, these rates are decreasing over time. Again, for these three indicators, men have higher rates than women, and people in the most deprived areas of Belfast also have high rates. So the good news there is that, again, even though people who live in deprived areas have higher rates, the time trends, if we look at those, these rates are decreasing, and that's particularly noticeable for early deaths from cancer for people in the most deprived areas. There's been a very large decrease there. So by assembly area, again, we get an interesting pattern. We get higher rates for men and women in terms of avoidable deaths, early deaths from cancer in Belfast North. We also get the highest rates for those two indicators in Belfast West. We also get a higher rate for men, early deaths from circulatory disease in Belfast North, and the highest rates in Belfast West. Again, as we looked at before, we've got lowest rates for men and women for those three indicators in Belfast South. It's interesting, though, there's a higher rate, if we move to Belfast East, there's a higher rate for women from early death from circulatory disease. So what these slides are beginning to show us is even though Belfast North and Belfast West tend to do worse, there are refinements to this picture, if you like, where for certain indicators, other areas of the city do need to be looked at as well. If we take admission rates in Belfast, just featuring alcohol-related causes and drug-related causes, again, it looks pretty bad for Belfast. It's higher than Northern Ireland. It's relatively high among other local government districts. But again, we have the decreasing trends in both Belfast and Belfast's most deprived areas. So the work that's going on is actually improving the picture. But again, we need to take account of the fact that people in the most deprived areas are the ones with the worst rates. If we look at just alcohol admissions by assembly area, similar picture. Belfast North and Belfast West are doing worse for both men and women as opposed to Belfast East and Belfast South. But the other thing that I think is very important here is to underline the difference between men and women. Even though North and West have the worst rates for both of them, for every single assembly area, you can see that the rates in men are either double the rate in women, or in Belfast North, they are 3 times the rate of women. So there is a real issue there for alcohol-related admission rates for men across the city. Risk factors, smoking status and alcohol status. Then again, highest percentages. This time we're not looking at local government district, we're looking at health and social care trust level. Again, Belfast does not do well compared with other health and social care trusts. I want to look particularly, though, at smoking during pregnancy. Again, not doing well on the comparison, but I think one of the troubling things is that smoking during pregnancy, in Belfast's most deprived areas, that percentage is more than double what it is in Northern Ireland. So I think that needs to be looked at for women in those areas. In terms of drinking alcohol, I think the most worrying thing here, because although we have higher percentages in Belfast Health and Social Care Trust, the differences are not so great. The differences start to appear when we're looking at the difference in above recommended weekly limits. And I think then that feeds into the data we've just looked at in terms of admission rates for alcohol-related causes. If we're now to sort of turn our mind to preventive services, looking at the cancer screening for cervical cancer, breast cancer, and bowel cancer, again, Belfast Health and Social Care Trust has the lowest uptake among health and social care trusts for all of these indicators. And unfortunately, there's a decreasing trend in uptake for cervical screening and bowel cancer screening. And again, we can look at that to see if that may be one of the factors in the early deaths from cancers, which we looked at earlier in the data for there. And as you can see in the slide, I've shown you that in terms of the coverage being achieved for Belfast, for cervical screening, the coverage achieved is below the acceptable target of coverage of 80% or more. And also for bowel cancer screening, again, Belfast Health and Social Care Trust is below target. However, the good news is there's an increasing trend for the uptake of breast screening. And here Belfast does meet the acceptable standard, which is equal to or more than 70%. But I think increasing people's access to and uptake of screening services will certainly help looking at the data we saw earlier on for early deaths in cancer. Moving on to mental health now, which Kira mentioned. Again, the picture is not great at first to begin with. Belfast has the equal second highest mean score for levels of anxiety, and it has the equal highest prescription rate for mood and anxiety. If we move on to look at admission and death rates, Belfast has the 3rd highest admission rate for self-harm and the highest crude rate for deaths from intentional self-harm. Again, the good news is these 2 rates are decreasing, so the work that's going on is having an effect, but we probably need to strengthen and accelerate it. If we look at by assembly area, again, we can see that Belfast North and Belfast West are the 2 assembly areas that do not have the best outcomes for either prescription rate for mood and anxiety or standardised admission rate for self-harm. However, it's important to take account of the fact that there may well be differences at lower levels, and I have a slide at the end that might show that for Belfast East and Belfast South. So I think you've probably, as I've gone through this presentation, had an idea that maybe outcomes for men are quite poor for some of the indicators. So I've just put up a slide here to show you where the indicators reveal poorer health outcomes for men in Belfast as a local government district. So there's quite a range of those, from life expectancy, death rates, and admission rates that we've already looked at, but that's just to underline to you that focusing on men's health would be a good thing to do, or to increase that focus for people already working in that area. If we look at the indicators where people in Belfast's most deprived areas are not doing as well, it's almost similar to the slide I've just put up about men's health. But again, you can see that across a basket of indicators, people in the most deprived areas do have poorer outcomes. And here I've looked at this in terms of 3 of the assembly areas, because Belfast South nearly always has the best rates for whatever outcome we're looking at. So I've just picked out here Belfast West, Belfast North, and Belfast East, and shown you which of the indicators by a kind of pale yellow shading where the area does poorly against each indicator. So again, life expectancy, death rates, admission rates. The interesting thing is, if we go to the bottom, is there's a very high standardised admission rate for emergency admissions for women in Belfast East. Again, that's just to highlight that there are some particular issues in East and South that need to be attended to that are coming out of the data, even though overall North and West are probably doing worse. Now, this is just to show you the outcomes for men by assembly area, and that you can see, again, it would be men in Belfast North and Belfast West who are having the poorer outcomes across a range of indicators. So some slides I haven't put up, but people asked me to highlight where we might be able to focus. And if we look at overweight and obesity, this is actually increasing in children and adults in Belfast, whereas it is decreasing in Northern Ireland. So there's an issue there. And it's also, there are especially high rates of obesity in Year 8 children and in children in Belfast's deprived areas. And the overweight and obesity, it links to the non-communicable diseases, but it also links back to that issue that Kira has highlighted, is that we need to do work on urban planning in terms of our community planning, looking at physical activity, the walkability of environments, the availability of active travel, etc. Children's play. Belfast Healthy Cities has done an awful lot on working with children to look at urban planning issues. So the overweight and obesity is, I think, a good area for Belfast to be working in. We've already looked at the decreasing uptake in cervical screening and bowel cancer screening. And one of the things that I think is interesting and is another area for work is the increasing prescription rate for mood and anxiety. And although I've said for a lot of indicators men are doing worse, there is a particular problem for prescription rate in mood and anxiety for women. So we've mentioned poor outcomes in men's health. We've mentioned Belfast West and Belfast North, Belfast's most deprived areas, and also the issue of high emergency admissions for women in Belfast East. This is my last slide, but what I've done here is to use the Northern Ireland Multiple Deprivation Measure 2017. They've got a wonderful thing called an analysis package, which I've been playing with. And in this slide, what I've done is I've shown you the 7 individual domains of deprivation, which, going from left to right, are income, employment, health, education, skills and training, access to services, living environment, and crime and disorder. And I've shown you the percentage of super output areas, that's a small jurisdiction that we use in public health. There's between 1,000 to 2,000 people in every super output area. What I've shown you is the percentage of super output areas in each of Belfast's assembly areas. So the first set of columns shows you Belfast East, the second set shows you Belfast North, the third set shows you Belfast South, and the fourth set shows you Belfast West. And those columns show you the percentage of super output areas that are in the top 20%, Northern Ireland's top 20% of most deprived areas. Now, what you can see from this, health in terms of the colours is grey. We've already noted that health is much poorer in Belfast North, which is the second set of columns, and Belfast West. And as you can see, 50% almost, it's 47 actually is the exact figure, 47% of super output areas in Belfast North are in Northern Ireland's top 20% most deprived areas for health. And then if we move to Belfast West, then 76% of the super output areas in Belfast West are in Northern Ireland's most deprived 20% of super output areas for health. So that shows the resonance between the data we've been looking at and the level of deprivation. But moving on to Ciara's point about the socio-economic determinants of health, we can also see that in Belfast North and Belfast West, there are other domains of deprivation that are very high. So the orange one is employment. Again, both Belfast North and Belfast West have quite high levels of deprivation in terms of employment. And also the yellow line is education, skills and training. And again, Belfast West and Belfast North have high levels of deprivation. And finally, if we look at crime and disorder, then again, Belfast West and North are the highest. So this underlines the point that health isn't just generated or looked after by the health service, that lots of different agencies need to come together and take responsibility for different parts of generating health and well-being. However, the other thing I'd like to point out here is what I was saying about looking at certain different aspects within, say, Belfast East and Belfast South that may need attending to. If you look at the green column, which is living environment, then we can see that, I think the figure is actually 46% in Belfast South. 46% of their super output areas are actually in Northern Ireland's most deprived 20% for that domain. So actually Belfast South does have an issue in terms of its living environment. Again, one can look at the data now and see where to focus. So I really found the analysis package that's provided with the deprivation measure very useful in helping me look at where we might need to target and how the levels of deprivation actually match some of the more standard data we've been looking at earlier in the presentation. Thank you.
Thank you, Erica, for that overview of the indicators and particularly the linkage between the indicators. And I personally find that last slide very, very valuable. Again, if you have any questions for Erica, please put them in the Q&A box for the last session. And now we're going to move on. I'm delighted to welcome Charlene Stoops, Director of Planning, Performance and Informatics in Belfast Health and Social Care Trust. And Charlene's going to take us on the journey so far and the road ahead for Belfast Trust. Charlene was appointed as Director of Planning, Performance and Informatics in May 2019, and she was previously Assistant Director of Corporate Planning in the Southern Trust. Charlene has worked for 20 years in a number of senior management posts within the areas of both corporate and capital planning, service transformation and performance management in both commissioner and provider organisations. Thank you, Charlene.
Okay, thank you very much, Karen, for the invite to speak today. Belfast Trust, as you know, have been supporting and working with Belfast Healthy Cities for many years now. And we really, really welcome the work that Erica has delivered now in terms of pulling together a very comprehensive data set for us. I really feel that that is the most essential building block for population health planning in Belfast. Today's focus is very much on people, and as Karen has outlined, what I hope to do is give you a bit of a flavour on my reflections on the work that we've been doing in Belfast, and what that roadmap looks like going forward. So I think the most important thing to recognise today is the fact that we are all joining this session for pretty much the same reason. We want to be able to support people in Belfast to live healthier lives. And that's one of the key outcomes of the programme for government. We want people to be able to maintain and be able to live in their own communities for as long as possible. And we need to be able to tackle the ongoing increasing health inequalities that we have heard outlined here today. So in terms of a population health planning approach, if we go back to pre-COVID times, Belfast Trust facilitated workshops under the branding of a caring and compassionate city. And really that was just about recognising the opportunity for closer partnership working in order to tackle the inequalities that we had identified. And we really recognised back at that point in time the importance of sharing and analysing population health data to support this new approach in the future planning and delivery of services. So that was a great opportunity to bring together many of our partners across the city. That included all of the stakeholders involved in community planning in Belfast, but it also provided an opportunity to work much closer with primary care. So we were able to involve our GP Federation leads and our integrated care partnerships and members of the community and voluntary sector as well. So I think it is important that we recognise the excellent work happening right across the city and the opportunity that there is to build on all of the work that has already taken place. Most important, I think, is making best use of the resources that we all have. So this is very much about how we can work better together. In Belfast, I feel we have a real opportunity to build on the existing partnerships that we have to focus on improving the health and well-being of the population. Our data would suggest that while as a system we are spending more money than ever before, as Erica very clearly outlined there, we are still seeing those increases in health inequalities. We are very aware of the increase in gaps in life expectancy, the drug-related mortality, and particularly around people reporting loneliness and social isolation. So the purpose of this slide really is to try to give you a feel for the fact that we have a very rich mix of resources and strong community assets in Belfast. So you will see there we have over 160 partnerships, 1,600 voluntary and community sector organisations, 10 healthy living centres, and we have a lot of physical assets as well. In addition to this, over the last number of years, there has been a lot of investment and development in community navigation models to support our signposting and wayfinding around what can become a very complex system. We've also developed a range of health improvement programmes and initiatives, and those are provided either independently or together in partnership between Belfast Trust, the Public Health Agency, and Belfast Council. And a lot of work has went into developing new primary care multidisciplinary teams, starting off with the pilot in our West Belfast area, but with the intention to roll that new model out into North Belfast and then across the city. So through our experience and learning from other cities that we have had over the last number of years, we feel we've been able to identify the absolute critical success factors. Work through our engagement and the previous work of the Belfast Strategic Partnership has really enabled us to better focus our efforts and our resources by better aligning staff that are employed by the Council, the Public Health Agency and the Trust. So now we have staff, for example, in my public health team, we would have staff within community development, within health promotion, within the delivery of care services, who not only have a trust-wide function and remit, but they are also aligned to services within North, South, East and West Belfast. And similarly, that has also happened with the council and the Public Health Agency. So we've been able to better align the resources that we have. Whenever we think then about the opportunities going forward, we have seen in Belfast how a partnership approach to connector services, which are commissioned or delivered by key players, is the absolute basis for improving health and well-being. Community planning presents us with a great opportunity. And whilst some progress has been made, and I have touched on some of the discussions that have happened across the city, undoubtedly there are many more opportunities that we now need to explore. Through the Belfast Agenda, work is ongoing to develop a programme of work on our shared priorities. And I've shown you here how in the Living Here Board work, we have agreed 3 proposed areas of focus, which I think you'll probably agree that from the data presented today, it's very clear that those are very important areas of focus. One of those is around complex lives, with an initial focus on people who are dealing with very complex issues. So that might mean that they are homeless, that they are suffering with alcohol or drug addiction issues. And we feel that through partnership working with the Housing Executive, the Police Service of Northern Ireland, the Council and the Trust, that we could really make great inroads to starting to develop new ways of working and better outcomes for those individuals. Also in mental health, and we also heard a lot today about obesity, and I suppose we have framed this around the importance of physical activity and obesity. Through the Belfast Agenda, there's also work ongoing on the other boards that exist, which will also help us to reduce health inequalities. So, for example, it recognises that there are wider determinants of health: housing, jobs, economy, environment. And so this is much wider than a health and social care issue, and that's where that whole partnership piece comes together. This is just a very high-level summary of the many programmes and initiatives that are running across and that are delivered by Belfast Trust currently. And because of the time constraints, I think rather than taking you through the detail of all of those programmes, I was going to draw out 2 particular examples of really good work that has happened over the last couple of years. The first I mentioned earlier is the West Belfast Primary Care Multidisciplinary Team. That is a new initiative that has been led by Belfast Trust and West Belfast GP Federation. It seeks to improve the way that patients' health and wellbeing needs are supported by GP surgeries. So it means that patients are no longer going to their local GP practice to see the doctor. They have an opportunity to access a range of other services. So that includes first contact physiotherapy. There are social work staff, mental health workers, who also are able to work alongside dedicated district nursing and health visiting. And we do have regional plans to roll that programme out. We've done quite a lot of work over the last number of months in developing outcomes-based accountability approach. So again, this is very much about focusing on understanding our data and the outcomes that our decisions are having. So the focus is very much on prevention, early intervention and improving wellbeing. And we have had a significant number of referrals across all of our services, with 37,000 patient contacts in 2021-22. And very recently, there has been work on small initiatives and projects that have been developed with partners to bring about improvements in waiting times, patient outcomes and experience. So crucial to this all is understanding the data, continually evaluating the work that is happening and the impact that that has had. The other one I wanted to mention briefly is around diabetes prevention, and the Trust did have initial funding coming through from Transformation, and we know that the incidence of diabetes is increasing. So the Trust had developed a prevention model. Referral has been very much through primary care into a service based on a 9-month behaviour change model, and that is designed to intervene at a point to avoid progression to a diabetes diagnosis. Since 1920, whenever this was first established, we have had 857 patients enrolled on the scheme, and our early evaluation has shown excellent retention and really positive impacts. So for those participants who wanted to lose weight, we have seen an average reduction in weight by 4 kilograms, and we have seen reduced blood glucose in 79% of those participants. During COVID, that programme moved online. it has proven extremely successful. And so the intention, like so many of our programmes going forward, would now be to offer more choice to members of the local community and to continue with a hybrid model. So a bit of a combination of both face-to-face programmes as well as online programmes. And then we come to the road ahead. So I've mentioned there all of the work we've been doing in terms of community planning. And within health and social care, the direction of travel now going forward is very much around an integrated care system. We feel that the strengthening of relationships and networks that we have had in Belfast provide us with a very strong foundation to now move into that more integrated system. So the intention is that there will be a more integrated way of planning and commissioning services in Belfast. I did mention previously the wide range of social determinants of health that influence health outcomes. So we know it's about age, it can be about your family, your community, your workplace, your beliefs and traditions, economics and physical and social environments. And this new ICS concept is about going beyond, again, health and social care, bringing other partners into the room to plan and commission services. So I think everything that we have done to date means that we're very well established to be able to take that forward. We are currently working to develop a framework for the new integrated care system model in Northern Ireland. And that will be brought forward for approval in the coming weeks, which would involve the development of a new area partnership board in Belfast. At a locality level, as models and partnerships mature, the longer term intention is to increase autonomy at a local level. So we would want our local groups to be able to have more control over the planning and the funding of services delivered within their localities in order to deliver the most appropriate services to meet the needs of the population. So in concluding, the question for me that continually comes up over and over again is how do we know that what we're investing in and what we're developing is what we need to do and what is right? And there are three primary building blocks to this, which I feel is very much what we've been focusing on in Belfast. Integration, it's about shared leadership and decision making, involving communities to shape direction and outcomes, and building on those really sound partnerships that we already have in place. This is where we need the data. This is why we need the work that Belfast Healthy Cities have led on to give us the information and knowledge about what's actually happening out there in the community, better understanding the challenges that we're faced with, and then we are better placed to agree our shared priorities and goals. It's very difficult to argue with the data and the evidence, and it's such a sound foundation for us to build on. We also need, as I mentioned through the West Belfast MDT work, evidence-based intervention. We need to do things that work. If it isn't working, we need to consider how can we veer our resources and do something different. So we need to continually measure our successes, our progress, and we need to review that and change as needed. So our work to date has told us that we don't really need standardisation or consistency in how we deliver services. What we need is local models that provide local services that can best meet the needs of our local people. But to do that, we need an integrated model and we need to be more outcomes focused. So very clearly what we need is the evidence and the data that will support population health planning and decision making in the future if we are to optimise the impact on the population in Belfast. So absolutely delighted today to be able to join everyone and hear so much more about the good work that is happening. Thank you very much. Thank you, Karen.
Thank you very much, Charlene, for sharing that information on the work of Belfast Health and Social Care Trust and the direction for the future. Again, any questions for Charlene, please put them in the Q&A box. We're now going to move on to the Q&A session. Ciara, are you still with us?
I am indeed. Yes, I'm here.
Thank you. Thank you. Maybe kick off then, Ciara, with a question for you. Could you maybe say a wee bit more about we being little, that's our Northern Ireland word, we, about the behavioural and cultural insights you had mentioned in your presentation?
Absolutely. So thank you, Karen, for that presentation, for that question. As I said, here in the region, as part of our 5-year plan, we actually have a flagship, which is about the behavioral and cultural insights. So again, understanding better, understanding our communities and recognizing that what we have just heard, both from Erica and Charlene, the need for local knowledge. And that local knowledge is really what we should be learning from, and that really is what should be allow us to tailor our approaches. I think, I mean, I know we are talking about NCDs today, but I think COVID-19 has really shown us the need to work hand in hand with communities. And I think during COVID-19, we've seen the need to really think about new and innovative ways of working, of using the cities, of addressing some of these public health challenges that we have. And I think what that has shown is that, part and parcel of what we do must be, these thorough consultations with our communities, because they are the ones with the knowledge. They are the ones who ultimately, have the knowledge in terms of what these tailored solutions should look like.
Lovely, thank you very much. And yes, they're a very important element of that. Just maybe then a follow-on question. So that's the community engagement. How do you engage all other sectors?
So I was really impressed with I really enjoyed the presentation and seeing how many partners have been engaged with throughout this process. And I think that's something that I always say we need to learn from, local governance, because for years we have now been saying and highlighting the importance of health in all policies. But we still have challenges around really coming together as different sectors. And I think what you have just shown here today is the importance of just doing that. And it is really about learning about each other's, not just agendas, but also learning each other's languages as well. And sometimes we sometimes think we don't have the time to do just that. But I think these complex challenges that we are seeing here, they cannot be tackled just by one sector alone. And therefore it requires that all of us make an effort to better understand other sectors' agenda. And with that, we will be able to make that progress in terms of coming together and looking for these more integrated solutions that was just highlighted both by Erica and Charlene.
Thank you. I see a question there from Colm Delaney about building resilience to climate change and the impact on communities. Could you maybe touch on that Colm's asking?
No, yes, absolutely. So, I mean, climate change is, as you know, one of the central components of the work that we do within the Healthy Cities Network as well, recognizing that cities play a key role in addressing just that. Again, I think we need to, consult with communities and think about how we plan our cities, both in terms of our transport, in terms of our housing, and learning from communities what these key needs are in terms of addressing climate change. So again, I would say that building resilience really require working with communities and understanding communities and understanding, again, it goes back to what I said earlier, getting a better sense of what the local knowledge is so that we can develop these more local tailored solutions.
Thank you. And you had mentioned in your presentation about that coherence following through into policies for municipalities. Okay, thank you, Ciara. We may come back to you. Erica wants to add something.
Yeah. Hi, thank you, Ciara. I just wanted to say that obviously the data that I've presented in the profile, and this applies for much of the 6 chapters in the profile, a lot of it is quantitative data, even if it's been generated in surveys. But I just wanted to underline how important it is to see the difference between the quantitative and the qualitative to underline the point you were making. The quantitative data shows us if or whether we have a problem, the size of a problem, but it's the qualitative data that will show us why we have a problem and what we might be able to do to address it. So looking at your insights work. And I wanted to say that I've been working in Belfast on and off since 2002. And one of the reasons I like coming here and doing community consultation here is I do think communities in Belfast have a very good understanding both of the ways in which they're resilient, but also the problems they have and why those problems have arisen. I'm particularly mindful of a bit of work we did in White Rock, where the community there had analysed their three main problems, how they interrelated, and we worked with them on that. So I think communities in Belfast, coming from a long history of community development work, do have a good understanding of the issues in their area, where their strengths and resilience lie. Again, we looked at that in Shankill at one point. So I think Belfast is very well situated now to take advantage of that and move into this integrated system that Charlene was outlining for us.
Thank you, Erica. And I saw Charlene nodding there in agreement.
In agreement.
So maybe Erica then, if I could move on, some questions for you. Within the demography data presented for Belfast, which changes provide the greatest opportunity to improve health and well-being and reduce inequalities?
Okay, so, sorry, just lost my pen. I suppose if I was to speak specifically, the thing that I thought about this morning, looking at the issues in Belfast North and Belfast West, as we've outlined it, what was also noticeable was they have the largest population of 0 to 15 years. And I thought, we talk about early years intervention and we say it's very important, but you have that ideal opportunity with Belfast North and Belfast West, which have the two largest populations of 0 to 15-year-old age group, to actually work with those young people. And that struck me as being very interesting. In terms of an ageing demographic, then I think obviously in Belfast East, there needs to be maybe a focus on the fact that they have the oldest population, more or less. They've got the highest median age. So those for me were two quite striking things, apart from the fact that in Belfast North, there's a kind of interesting service dilemma where you've got a large number of 0 to 15s, but you've also got a larger number of over 65s. So in terms of service planning, you know, community planning, you've got those two segments of your population that are increasing that actually, you know, is going to be challenging for service planning, but also maybe an opportunity to be innovative. So those were the things that stood out to me when I was reflecting on the data this morning.
Okay, thank you. And in the early years, would you see pre-pregnancy and pregnancy as being in that?
I think it is important as well from the data. I didn't put up the breastfeeding data, you know, I only had 20 minutes, and if I have too many slides, then I talk forever. So I know you wanted to avoid that. But smoking during pregnancy, breastfeeding after discharge from hospital, both of those will affect both the child in the womb, you know, neonatal health, health throughout a child's life. So certainly, yes, I think that's very important, especially in Belfast's most deprived areas. Those two indicators highlight a need for maybe more focus there, strengthen the work that's already going on or accelerate it in some way. So certainly during pregnancy, that could be part of it. Also, for those of you, and a sort of little advert for our next chapter, but I'm currently just finishing prosperity, and we look at the education indicators and some of the educational needs in the prosperity chapter, and I think we can tie in some of the poorer outcomes, especially at a district electoral area, with some of the health and well-being work that's going on.
Thank you. Charlene, do you want to come in there at all, or?
Not necessarily on that page.
Okay, that's fine. Yep. Erica, you also pointed out in the data where some progress has been made with services interventions already in place. So what do you think can be learnt from that progress and what can be built on?
I think the heartening thing is that for most of the indicators, the trend is going in the right way over time. So if we forget the comparison and, we don't go into a council of despair, because I think it's easy when you look at data to do that kind of thing, is to say whatever is happening in the city amongst both public, private and, community and voluntary sectors, everybody, as Charlene very rightly said, they all want the same thing. We all want better health, well-being, prosperity for the population, wherever people live in the city. So I think look at what is being done, and as Charlene, I think, rightly said, evaluate whether you're getting the outcomes you need from it. To reflect on it as an entire system, then from work we've been doing within integrated care systems in England, that I've been working with Professor Samir Gray on, I think it's very important that you have more formal systems where you have a set of agreed system objectives, aims, not just shared priorities, but everybody is working to the same set of objectives, and that beneath that you have outcomes. I would also, I think, from the experiences in England, if I'm allowed to say this, outcomes-based accountability, I agree with it, but one has to be very careful on the outcomes one chooses, the outcome measures one uses, and also not to forget that process measures are also important, because if you have a good process, it doesn't necessarily mean you'll get a good outcome, but if you have a bad process, you're not going to get a good outcome. So process is also important, even if you have an overall set of outcome measures, then process measures are also important. And I think within running a system, then you also need some form of management of that system so that you're running more of a managed network rather than an informal network within your partnerships. I think those are very important things. So the wealth of sort of community development work going on in Belfast is fantastic. But as Charlene said, the point now is to make all that work be integrated so that there is the focus there, you can target, but you do need a system set of objectives that everybody's working to and different people lead on different bits. And that's actually quite tricky.
Yeah, and the other thing about the process measures is it also lets you see why something might work in one area and not another area. Yep, Charlene.
Thanks, Karen. Yeah, I would like to come in on that one because I think a lot of our conversations over the last couple of years have been in an ideal world where we would like to get to is to be able to try to map our data out across all of the organisations that we're working in partnership with. So we know that we all have really, really important data. Yep. We haven't got to the point of being able to map that all on top of each other and being able to understand why are there the pockets of deprivation, why are the differences across the different areas of Belfast. I think another key bit is when you map on top of that the physical assets, where the initiatives are, where the programmes are. For me, there's a big ask about equity. We need to be able to stop, evaluate what services are we delivering? Are they being delivered in the right place? Do we need to actually veer and provide something slightly different? So I think that this is a really, really good foundation for us to build on that. But you're absolutely right. I totally agree with what Erica has said there. There's something about how you formalise these relationships. Because you need very clear governance, you need to agree who takes responsibility, because in the informal working, while it's really good and it's good at developing relationships and networks, you need to be very clear around Belfast Trust are going to take the lead on that, or the council are going to take the lead on this piece. You might all be in the room, but you need to know where that sits. So I think that's why it's exciting through the integrated care system model, also community planning. Because a big challenge for us is understanding what sits where. And I think we have a key piece of work to do around that leadership piece, divvying up the tasks and then starting to be able to evaluate that. You also mentioned the evaluation of the work that we're doing. So again, we tend to do small initiatives in pockets of different areas of Belfast. how do we know that that's actually making a difference? Some of that is very, very difficult because I think especially in health development world and looking at inequalities, it's very long term. You're always saying 5 years have passed, 10 years have passed, we didn't quite get to where we would like to get to. And I think that the big challenge for us is how do you start to set shorter and medium term objectives and targets and clearly monitor that what you're doing is right. It's too late to spend a lot of money and 5 years down the line or 10 years down the line realise it didn't work. So it might be about starting on a very small level in a couple of areas, but I just think that that's the place where we need to be.
Yeah, and again, the process measures will help you see why things are working or aren't working. Thank you. There's a comment in, Erica, for you from Catherine Robertson, the Women's Resource and Development Agency. Catherine says they have a contract with PHA to deliver awareness sessions in breast cervical and bowel screening. And the past 6 months, they've focused on working with men in the men's shed. And after lockdown, and sessions have been very popular with the men's shed, the bowel screening sessions.
Great. I mean, that's that's absolutely needed and absolutely well done. I mean, you know, the data for the bowel cancer screening overall for Belfast, so it's not separated by men and women, but it's below 55%. So, you know, the work they're doing is absolutely vital to try and increase that percentage, because bowel cancer in itself is not a nice thing to have, basically.
Thank you for
I'll
that.
just maybe add to that, Karen, because screening uptake, it is very difficult, and I was quite surprised by, you know, the fact, the data that you presented today, Erica, I have to say, around that and how far we are off where we would like to be. And there is excellent work ongoing, and it has certainly been mentioned to me about the work of the Women's Resource Development Agency. So it is very welcome. That's the sort of thing that we do need to see at a very wide level and across all of those different screening areas. So thank you very much. Thanks for that.
Thank you. Erica, you had mentioned how we can work with the very young, the early years population up to 15. What about that next age group, the young population, 16 to 39?
Funnily enough, I was talking about that with my dental students yesterday.
Right, okay.
I think it's very important. I think one needs to remember that actually your brain doesn't stop developing, you know, until you're about 25. So particularly the age group 16 to 25, 26 can be quite vulnerable. They've left home, maybe, you know, there isn't that much parental guidance. They might let they may not be as good at looking after their own health as being with mum and dad at home. So I think, yes, it's very important. Also, the other thing I'd say, reflecting on that, at the moment, Belfast prosperity is coming from that younger, the largest, you know, they've got the largest young working age population compared with other local government districts. So if you like, the 16 to 39-year-old age group is more like your engine for generating a lot of the city's prosperity and well-being. So I think it's important, if we focus on 0 to 15s, I think it's important to do what's known as proportionate universalism. You know, we mustn't forget about other age groups and how important they are. Attend to the needs that younger people have. Quite often, younger people going from a 16 into a 25, post-25 age group, when they're then, you know, neurodevelopmentally adults, there's often a disconnect with services because health services in particular may not be aware of younger adults' needs. So I think that is an area we can look at in terms of just access to health services in general, whether it's preventive, to do with mental health or whatever, and be more innovative. But that age group, 16 to 39, is basically the foundation of your city's prosperity at the moment, as I see it, you know, and among the LGDs, you've got the highest percentage of 16 to 39-year-olds. So looking after your younger working age population will pay dividends. And then, of course, if their health is good, as they become older, they move into older cohorts, then hopefully they'll maintain that good health. So I think it's an important age group to define what their needs are and then address those needs, because that's where at the moment your prosperity is going to lie.
That's very helpful. Thank you. Colin Delaney from the RNIB has pointed out an issue, and whilst we didn't have data down to specific maybe disability groups or things like that, Colin has made a very good point, and maybe Charlene, this is relevant, well it is relevant to yourself. It's a big issue getting timely and accessible health information to blind and partially sighted people, and is aware of horror stories of people having to open and read private health information on behalf of someone else or missing very important appointments. And obviously an ageing population will mean there's greater numbers of people with visual impairments. So, and could only get worse without a standardised approach. Are you aware of anything in the trust that's being done in terms of a standardised approach for this group?
The best person to speak to here would be my equality lead, if she was here today,
Okay.
because she would be able to give you a really good overview of lots of different work happening in this space. So there is work ongoing, particularly around making information more easily accessible, more user-friendly. A lot of work goes into how things are presented. There's also been investment in the trust in terms of mobility schemes in the hospital sites, helping direct signpost people around the hospital, all of that navigation and signposting piece. But I totally agree with Colm. I would imagine, it still is a very, very big issue. And by no means will we have this one cracked. It gets, I suppose, exceedingly difficult because there'll be so many individuals, and unless you're providing really person-centred care, it can be difficult to do that when you look across at a very large scale. So primary care, community care are really the areas of focus for me that I think we would need to make a real difference in. I think I would be keen to explore further, particularly with the West Belfast MDT and having community social work and mental health staff in there who link very strongly with our community teams and through community development and health promotion, if there's something ongoing in that space. And I'll certainly take that away today, Colin, to have a further look at that, because this is one of those important equity measures again. It's about making sure that people are getting the service they need. So certainly we'll do that. Thanks, Karen.
Thank you. So maybe following up sort of on that general area, could you please outline for us how Belfast Health and Social Care Trust work to support information on avoidable deaths, which can be prevented through public health and primary prevention interventions? So it's about the information here rather than the services.
Okay. And I suppose I did mention earlier, we have a range of data. We have lots of data in the trust, as all organisations do, but we aren't very good sometimes about how we share that and make sense of that all as a system. So we have hospital and we have community systems within Belfast Trust, all with very rich data in there. So you are able to drill down, you're able to look at who your frequent flyers are, you're able to look at according to postcode area, why are there more ED admissions from a particular area? Is there more respiratory illness? So I think it would be a really important and good piece of work to be able to start to layer that on top of the work that has been done here today. And those are the conversations we've been having, again, through community planning approaches as well. How do we get to the point of bringing all of those different pieces together? A lot of our data, obviously, it goes regionally as well, and obviously that's, Erica, where you will have been able to get some of your data and information from. But also what is more important to me is it's about linking the data with what people on the ground are saying, and that the perception doesn't bring something slightly different to that, because it's the sense-making piece. It's not just about counting the numbers and counting the activity, it's what's going on behind that and what you need to put in place to turn it around. So we obviously have a big focus in the trust on prevention and early intervention. And I mentioned there about aligning our community teams on a north, south, east and west basis. I think that's a good way to get in on the ground, to understand what's happening. It means that our staff across the different organisations are now working together as mini teams across Belfast rather than this very broad approach. So I think all of that will come to the fore on the back of that good work that's happening.
Thank you. Erica? In there?
Sorry, just to make a point about information and working in a system across various organisations. One problem we've had with integrated care systems in England, so that you can learn from some of the punch-ups we've been having, is the interoperability of systems and the difficulties we've had in getting agreements to share data. So even though an integrated care system, you know, in theory is a good idea, and the whole idea of being able to share data among organisations, it's actually there are some barriers to it that need to be sorted out. So not only the way different organisations, you know, store their data, are the systems interoperable, are they collecting them at the same level, and what I think, I mean, in England we were being encouraged by our politicians to share data, but then there are various rules that we're facing that mean we can't, and there doesn't seem to be a way to unblock the system at the moment in terms of the legal requirements. So there are those issues as well that learn from our mistakes.
Absolutely. And we have had quite a few conversations about that. I suppose information governance sits with me in the trust as well, so I'm very au fait with the constraints around that. And we are having regional conversations about how we can do that better.
Yeah.
I think that's the good thing. From the integrated care system perspective, there's been a lot of work with the councils, the Department for Communities and others around how we can get to a point of being able to do this better. But it's going to be a huge challenge.
Yeah.
And we know even within the organisation, once you even get down to postcode level, people can start to become identifiable.
Yes.
So yeah, very aware of the challenges that there will be in doing that. So the concept is good, and the practicalities are not always just so easy.
And I would totally concur with that, because under the practicalities, I was trying to do a research project, and you know, I was told could get the data from all these different organisations, but as you say, the legal processes aren't in place yet. One final question then, maybe Charlene, for you. Then around the timely and effective healthcare interventions, you had mentioned a number of them on your slides. Would they be the main ones you have mentioned? I know there must be lots of others.
Yeah, so I did flag up, and I know the presentations will be shared afterwards, just some of the it's really at a very high level, obviously, Karen, in terms of the different initiatives and programmes that are running at this point in time. I think the other bit is that can be as important to support those initiatives and programmes is all of the information and the communication, and how we're getting better at using websites, using podcasts, using social media. I think that's very strong. And whenever you talk about younger people and even the 16 to 35 age groups, I think people are much more attached to their phones and that they work differently. So sometimes it's about giving people enough information to help them decide and make a choice in what they would like to do going forward. So those are some of the things. I did also mention there service leaflets and how we present those and how we publicise those. But the strongest thing overall is about recognising what is happening in all of the different areas and making sure we're using our resources best. So we are not all working in one area delivering the same initiative or programme when we need to start being able to scale that up and roll it out right across Belfast.
Yeah, thank you very much. Thank you all of the panel members for those insights. And I'm just going to hand over now to Joan Devlin, Chief Executive of Belfast Healthy Cities, for some closing comments. Thank you.
Good afternoon, everyone, and I think you'll agree with me. We've had an excellent session this morning looking at the people chapter of the City Health Profile. My sincere thanks to all of our speakers. But just to recap on some of the key messages, I mean, we started off with Ciara from WHO, and really some of the messages that Ciara was emphasising was how will the population benefit equally from the various services or interventions. Where you are born matters, and that was reinforced by some of the data that Erica presented and some of the comments from Charlene. And how do we use that? And again, this was a point raised by both Charlene and Ciara. How do we ensure that we apply the equity lens to many of our programmes and interventions. We just can't provide the same service to every population group. And some of the key issues are around child poverty, some of the facts that Ciara was giving us around child poverty and air pollution, and then also provided examples of best buys. And many of those examples of people, some of the audience particularly want more information, then do contact us and we will be able to provide that from Ciara. Erica's presentation very much looked at the aging, the demography of the population, and we realise that in Belfast our population, we have an ageing population, but it's not. We don't have an ageing population in comparison as big an ageing population in comparison to the rest of Northern Ireland. Some of the issues that Erica raised were in relation to men's health. But that on many of the indicators actually in Belfast, we are making progress, while there's quite a gap between some of the populations in Northern Ireland and populations in Belfast. We do have to keep in mind that we have a highly deprived, parts of Belfast are highly deprived, and that some of the very good work that is going on actually is making some progress. Men's health was mentioned and was also mentioned again by Charlene. And I think Charlene's point around, welcoming the data that is being made available through this profile. And just to say, that while the City Health Profile is a requirement of being a World Health Organization designated healthy city, it is also a valuable resource both to citizens, but particularly to voluntary and public agencies across the city. Charlene continued to outline some of the excellent work that's going on across the Belfast Trust, and concluded with some of the newer initiatives that will be taking part, and Healthy Cities are also involved in the community planning process and in some of the development boards. So I think it's been an excellent morning. The question and answer panel chaired by Karen actually generates that good discussion, broader discussion on many of the issues raised. There are challenges, but I think you can see today the commitment that is outlined from the Belfast Trust and from others engaged in addressing some of these issues. So sincere thanks to Ciara. Lovely to see you again from WHO in Europe. And we hopefully will get the opportunity to meet in person very soon. Thanks again to Erica for all of the work that she has done on the profile, to Charlene, because I know people have very busy programmes, so we do appreciate you taking an hour and a half or a couple of hours out of today's programme. And last but not least, thanks to the interim chair of Belfast Healthy Cities, Dr. Karen Casson. And our next chapter will be on prosperity. So we're aiming to have that mid-June, but the details of that we will put out next week. The recording of this session will go on our website and I think earlier Caroline put the link into the chapter today. So all of that will be available on the website as well as the slides. So have a good day. Thank you for attending.